Good morning, good afternoon, good evening, and welcome to the next in our series of In Conversations With, organised by the Lancet Commission on Gender and Global Health and the United Nations University International Institute for Global Health, Gender and Health Hub. I'm really delighted to be with you all today. Thank you for joining us on the multiple and various platforms that I know that you're all joining through. My name is Sarah Hawkes. I'm one of the co-chairs of the Lancet Commission, and in a little while I'll come to who we're going to be in conversation with. But before I do that, perhaps I could just ask to be moving on to the next slide. Thank you. So if you're watching me speak, you're undoubtedly fully aware of how you can join this conversation, because there are multiple platforms, but it is a conversation. And so this isn't just us talking to each other. This is us wanting to hear from all of you too. So what you'll see on this slide is, irrespective if you're joining us through Twitter or through YouTube or even through Zoom, you can put your questions to the speakers or send us your comments that we can also put to the speakers too. What you'll see here is the hashtags and the handles on Twitter, where you can tweet your questions or comments at us. You can put comments under the YouTube live stream, and of course, everybody is now familiar with how to put comments into the Zoom chat, and we will collate all of those. So don't be afraid to share your ideas, your questions, your comments with us, because as I say, the whole purpose of this series of conversations is for us to have a dialogue with all of you. When you do send your comments and questions, please remember to tell us who you are, so that we know where the questions are coming from, not just your name, but also, if possible, which part of the world you are joining the conversation from. Thank you. So if I could move on to the next slide, please. We're going to start the conversation with a short presentation from Professor Simone Diniz, who is professor at the University of Sao Paulo in Brazil. And Simone is joined by two colleagues, also from one from the University of Sao Paulo, one from the University of Brasilia. I will leave Simone and her colleagues to do more fulsome introductions of themselves. But once Simone has given her presentation, there will be a panel discussion, and after that, we will move into the question and answer session, led by all of you joining us on various platforms. So with no further ado from myself, I would like to hand over to Professor Simone Diniz, Professor Ana Flávia D'Oliveira, and Professor Daphne Rattner. And just a quick reminder that Simone, we're absolutely privileged to have Simone as one of the commissioners on the Lancet Commission on Gender and Global Health. And our three panelists today are going to be speaking about a subject that is dear to the heart of anybody who uses health services anywhere in the world, which is the issue of gender violence within health institutions. So, Simone, over to you, and thank you.
Thank you very much, Sarah, and thank you very much the Lancet Commission, the Health Hub, the Gender Hub, for the opportunity and the privilege to be talking to you and learning from you and thinking about opportunities of collaboration. So let's start the presentation, and I'll try to keep to my time. It was difficult, and I want to thank especially to Tiffany Ansari for her patience and her very careful organization of this seminar. We have changed it several times, the way we would organize a seminar, and we hope it's going to work Well, the idea is to leave some time for interaction and for dialogue. So next one, please. Next one. So first of all, setting the scene. It is a coincidence that 20 years ago in May 2002, there was this publication in the Lancet of this paper, Violence Against Women in Healthcare Institutions. By the time it was an emerging problem, and now we want to see how much we have, what kind of initiatives and responses were created after that. So in these 2 decades, we had a very important increase in new names and new descriptions of the problem. One of them that's very interesting is the idea that we have both too little too late care, especially in low and middle income countries, but also we have, together with this, the issue of too much too soon care. And this is a very intersectional form of violence. But one of the descriptions of this is the issue of institutional gender violence. And one of the things we want to invite you is to think about the issue of epistemic justice and how these voices come from the South. And I was hearing the last seminar, and Tiffany talking about the issue of cognitive and epistemic justice, as she was quoting Boaventura Santos about how this relationship in terms of knowledge construction, we could improve in terms of cognitive and epistemic justice in terms of collaboration. And we'd like to talk about what works for change. Next, please. So why we call this gender? We had some previous seminars, very interesting thinking, talking about the need of sex disaggregated data, gender indicators, and many other issues related to gender and also related to sexuality. But here we mean the idea of the essentialistic idea that's even in public health too, this idea of the correctional approach to women's body, the idea that women's body is defective and benefits from routine correction. So this leaves a set of gender biases and the blind spot with overestimation of risks and discomfort of physiological birth and overestimation of the benefits of medical and surgical intervention, and also the underestimation of risk and discomfort from intervention and the underestimations of the benefits of normal, including the new debates on the biology of childbirth, including the microbiome, the epigenetics, etc. So we have in public health and in global health some blind spots in terms of gender. How the women's experience and families' experience are pessimized, and the issue of iatrogenic harm, but especially the profound contradiction between evidence and practice, and in many circumstances, the refusal to change in institution and in training. Next one, please. So we had many initiatives in this last decade, since the 1990s, we have in Latin America, for instance, the movements for the humanization of childbirth that very much builds into 2 frameworks: the human rights and then human rights in health, and also the idea of evidence-based healthcare. We benefit very much from the initiatives such as the WHO initiatives, the building of a body of evidence in childbirth care that was very politicized by social movements in terms of stressing the distance between what was the best evidence in terms of science and what we had. But this was limited because of several issues, especially the idea of our alliances and the idea that humanized care would be a luxury in poor setting. Next one. So obstetric violence is very intersectional. So we have, we understand that there is a hierarchy of motherhoods, and that the respectability of motherhood and reproduction is dependent from the issue of sexual partnership. The issue of racism is very structural. So we treat women differently in the system. And some of the issues we want to resume the analysis, for instance, about the marital status and how the issue that we have in the top of the pyramid, white, married, middle class, single women are not treated the same. Those who are too young to, with disabilities, seropositive people, the issue of mental health, transgender, drug users, and sex workers, incarcerated women. The distribution of obstetric violence is different among society. Next, please. So we have many terms used for this problem as a frontier object. So since the 50s, we have the idea of cruelty, dehumanized care, human rights violation. It's very important to stress that in abortion, we have much more violence. The people also call gender institutional violence, obstetric violence, obstetric abuse, mistreatment, disrespect and abuse, which is a very much used. I like them all. I think that all these terms can be very self-explanatory. They make more sense in some languages than in others, but I think that all of them are very indicative. And one of the most promising one is the idea of reproductive justice. Next one. So in this process, we also were able to think about new ways to describe the situation, and also the creation of new indicators, because since this was a gender blind issue, we had little information about this. For instance, about episiotomy or perineal outcomes. That's very much related to women's sexual health, and the issue of the right to companionship, the choice of position, the verbal abuse, the issue of fundal pressure, the issues related to false information about baby safety, the right of choice for place of birth, the right to informed choice and refusal. So we need to create new indicators, and there are several very good initiatives classifying these forms of violence. Indeed, we need something that we could work across countries and have international comparison and studies, and it's an important need that we can have comparative data and create comparative indicators. This is one of the challenges. Next one, please. There's a linguistic issue related to obstetric violence. I think in some languages it sounds easier to understand than in others. But even in high-income countries, for instance, I show you this is an initiative from France, but you have many others in Italy, in Portugal, in Spain. Also, in terms of obstetric violence, the issue of obstetric violence and the calling it with respect to abuse or mistreatment or whatever have been used in mainstreamed institutions such as the WHO and in training programs. And there's a lot of very rich production about obstetric violence in Africa, also in Asia, and there are very a whole lot of new issues that are being brought into visibility. So the idea is that women are understood not as victims of their own violent body, but submitted to gender institutional violence in maternity care. And in some places, they also call the attention to gynecological violence and neonatal violence and bringing new research subjects and activism. Next one, please. One of the strategies to promote respect for care and in terms of gender equity is the issue of midwifery. It has a whole component of reparation and decoloniality, especially because almost all midwives are women. So it's also a form to invest power, money, and resources for women, to professionalization and income of women, but there's a very important need to invest in training that is gender sensitive, because not necessarily we have gender sensitive midwifery, and midwives need to be supported on this. They are central figures to the fight for the rights of women, children, and communities. And also, they need very much support for decent work and protection from discrimination. Next one. So these are some of the questions that I want to share with our colleagues here towards thinking in terms of solutions. So how social movements and local international level can confront abuse and disrespect both in the South and the North, and how to deal with professional conflicts of interest, including those in global health. We would like to invite you to share your experiences about this, and how can educational institutions and government help or hinder change. In Brazil, some of the most resistance to change are educational institutions, but there are many initiatives to address this. And how can we have new words, concepts, indicators, and variables? I think I have a last slide, right? Okay, and resuming the issue of contemporary challenges. Why did it take so long? It takes and it took so long for the recognition of abuse and disrespect. And what are the barriers and enablers for change? And what could be our allies, and how our allies themselves could be barriers or enablers. And if there is here an opportunity of what people call reverse learning from the south to the north, is there a reverse learning opportunity in terms of experience, in terms of how people start to describe this new phenomenon, and thinking then in terms of intersectionality, coloniality, gender, racism, and how we could collaborate on this. So these are the questions that I want to share with my colleagues, Ana Flávia and Daphne. And they were introduced very properly as professors and academics, but both of them have both feet on activism, and Daphne is also the chair of the National Network for Humanization of Childbirth. It's been an activist for decades, besides being an epidemiologist in maternal and neonatal health. And Ana Flávia is a very internationally researcher and activist on the issue of violence against women since the multi-country studies in the 90s. So I invite them to talk about how knowledge itself have changed and how we can use the production knowledge through research and through teaching, but in relation with our activism to change reality, and how we could collaborate internationally regarding this. What's the role of this in global health? So I will first ask Ana for this set of questions, and afterward to Daphne. Thank you.
So thank you very much, Simone. Good evening, good afternoon, good morning to everyone. Thank you for this honor and this invitation and the opportunity to share with you a few reflections on such an important theme for healthcare. And this, for me, it's like coming back, you see, to something I've been for a long time ago looking at. And when in 2002, Simone and I wrote this paper, and I was just remembering there's a spirit of the conversation, violence against women in healthcare institutions, an emerging problem. This problem, institutional violence, and this form of institutional violence, obstetric violence, was just being named around the world. And it still seemed a little weird at that time. I think it just still seems a little weird in some places, even today. At the University of São Paulo, where we work, some professors were shocked by the publication. They told us that it was not right that we have in space to write at such a prestigious journal as The Lancet had chose to expose such a bad image of Brazil, talking against doctors and health institutions. We didn't mean to talk against them. Violence is not easy to recognize, and its perpetuation is based also in this trivialization and naturalization. This is true for intimate partner violence, for domestic violence, for sexual violence, and violence within our universities. When we started the Brazilian branch, I was the PI of WHO multi-country study on women's health and domestic violence in 1998, 1999. Our research group was called at the corridors of the faculty the violent women. Look, they are the violent women. We were the women showing first time in Brazil with rigorous epidemiological methods the prevalence and health consequence of violence against women in our country. Still at the corridors, we were the violent women. Later, in 2014, 2015, we denounced sexual violence and abuse inside the university, perpetrated by colleagues or professors. And we had to create an activist social movement called Don't Stay Silent, our network of professors to defend and protect students from violence, abuse, and disrespect within the university. Because the formal mechanisms were inexistent or they just did not work. Students were blaming by the violence they were suffering and experiencing. And we got the same reaction. If you talk aloud about this, you are going against your own community, your own school. Naming violence as violence is a way to challenge its presence, its trivialization, its naturalization. But it may also be very threatening for those who want the issue to remain invisible in order to go on with their privileges. Stay silent, they said, and we will solve the few bad apples within our group, our institution. Shut up. No publicity or action out of the walls of the medical school or of this hospital. Do not dare to stain the name of institution. The doctors respect. The public opinion may be against us. We responded to this criticism at the time and even now, but much less now, stating that this is a structural problem deeply rooted in our knowledge, practice, and institutions, and need to be faced in order to change healthcare and society. We understood and made clear that a violent institution is no shelter and cannot support women experiencing domestic or sexual violence. And this is a precondition to support survivors. The service not to be violent itself. We cannot deal with violent health services, and we need to face it. We don't want to destroy the institutions, we want to improve them. Silence is allied to violence because it hides the problem. Fear stops real open communication among people. To hide the prevalence of violent acts does not protect our institutions, whether family, hospitals, or universities. It damages them. It does not stop violence, it perpetuates it. The consequences of different forms of gender-based violence in our societies are now much better known, and they are enormous, as we have been showing in the last 30 years with more and more scientific evidence. All those types of violence, intimate violence, violence in universities, obstetric violence, are related, and they are based in gender inequalities, in intersection with class, race, and other power axes. Those are violence against women, all women. And those are forms of violence which can be extremely perverse and worse for more vulnerable women, worse for Black women, poor women, homeless women, lesbian women, We are not just one woman. We are women in our diversity, and violence affects us all, but in different ways. 20 years ago, we are already aware in the past, you see, we are already aware of the presence of abuse and disrespect in health institutions, and we named it as institutional violence. It is difficult to believe, and it's very upsetting, that in the very place of care where people are suffering and needs treatment and cure, violence is present. But unfortunately, it is a reality, as research and activism have improving across the last 2 decades. To acknowledge violence is the first step to understand and to be able to change it. We can use other names depending on the settings and on the allies, but the acts, as I learned in the WHO multi-country study, are there. We call violence violence because it turns a difference into inequality. And this is Marilena Chauí, a Brazilian philosopher, that defines violence as something that turns a difference into inequality and a social subject, a human being, into an object, a thing, a body. To stop institutional violence and the medical system reproduction of gender, class, and race inequalities, we need a huge change in the health system, in the health knowledge, and in the health practice, putting the person, in this case women, at the center of care and recognizing them as subjects. Women are human beings and women's rights are human rights. Women should be able to participate in the decisions of their own bodies in healthcare everywhere. When we know, we can measure it. And a representative national survey in 2010 in Brazil showed 25% of reported violence among women delivering their babies and 53% among women who performed abortion and went for medical assistance in Brazil. The most common forms of violence measured there were verbal violence, threaten of no assistance, blaming women, and saying, when you did it, you like it, so now you don't shout. Unfortunately, this phrase is so common around the world, not just in Brazil. In 2002, we already had more than 10 years looking at and acknowledging that violence could happen within the health system. Learning from South America's social medicine, we knew since medical residents that health institutions and health work are not detached, but part of the whole society, with its own intimate logic, but deeply embedded in society as general, contributing for its organization and being partially determined also by the society. We knew medicine is not neutral nor sacred. Medicine is a work and produces and reproduces society as a whole, being deeply interconnected economically, socially, and culturally with the whole society. We are not a silos. This basis from social medicine and the huge social feminist activism may have been the responsible for the strong role of participation of Latin America in defining and measuring the obstetric violence phenomenon and point solution to it. This is a global problem which presents itself different in each country, each population, but it's everywhere, global south and global north. We need to learn together and from our differences across the world how to overcome it. There is a lot of knowledge overlooked from our ancestors, from the native people of our countries who had their knowledge repressed. We need to advocate for cognitive justice, as Boaventura de Santos say, and search for different forms of knowledge than science that will help us to transform care and birth care into a more pleasant, healthy, and meaningful experience for all involved. So, when activists show the problem, the medical system is part of it, but it is also part of the solution, together with many other carers and knowledge around the world. When we look at the training on medical and nurse schools, we can see the learning of a way of dealing with patients that do not consider women patients as subjects, as human beings, most of the time. A researcher from Brazil called Rochinski, she did an ethnography of the learning of obstetric in the undergraduate medical school. And she shows how students learn to examine women who just delivered their babies and are in hospital beds as if they were pure bodies with no intention, dignity, or wishes, looking at their breasts, vaginas, secretions as if there were no human being there. Maybe a week high when they arrive. Thank you when the crowd of professors, residents, and students move away to the next bed. We learn to objectify people as mechanic bodies with no rights or opinions, and obviously with no moral authority over their own bodies and lives at medical and nurse school. To be fair, I need to say that we are changing that, and Daphne will tell us how and how much. But to change the teaching is to change also the practice scenarios. So it means also change the hospital and primary health clinics routine and care. In many places, also in Brazil, projects to improve the quality of care, safety, and respect are being done in training hospitals, and this is mission critical. We did a lot, and Daphne will tell us now how much. But there is still a lot to be done. In Brazil, current government try hard to make the term obstetric violence illegal, prohibits it inside the government publications, and speaks against it. The primary healthcare secretary for the Ministry of Health in Brazil puts in the governmental educational material the encouragement of episiotomy and even fundal pressure as good practices, which should be encouraged. The word obstetric violence is being prosecuted for the very people who should combat it. But we are here, the ethical professionals and professors. Sorry, the women's movement. I've got an echo. We are here to put light at obscurity and promote change in health system towards respect for diversity and the best possible care around the world in all its beauty and diversity. Thank you so much for the opportunity. And I'll give the word to Daphne.
Thank you very much, Nana. We are very enthusiastic, and we took, both of us, more time than we should. So I asked Daphne to be as short as possible for us to allow for people to interact. Thank you so much, especially for bringing the issue of stigma for those studying traditional violence. To you, Daphne.
Thank you very much for the opportunity, for the honor. I'll try to do my best. But I want to say that as the president of the Brazilian Network for the Humanization of Childbirth, this network started as a response to violence in obstetric care, and there is this mention in the letter of foundation. And also in our first seminar, Ana Flávia was there to talk about violence in obstetric care. We were reminded by this fact. Yesterday, it was in 1996. So when she says that in 2002, she was already on a long way on the road. Yes, she was. We will talk now about ways to change. And I see two big motors of change. We have the international organizations. They have a very strong role telling us about how to change. And we have the grassroots movements such as ours. And I will talk about the example in Brazil. As for international organizations, I would like to mention WHO that since 1985 started talking about appropriate technology for birth. They published in the Lancet, which is receiving us today to talk about. And they already talked about that every woman has the right to proper prenatal care and has a central role in all aspects of this care. This is valid till today, and it doesn't happen, even if it is since 1985. Afterwards, Simone already mentioned Care in Normal Births, a practical guide from 1996. In 2008, we have the International Mother-Baby Childbirth Organization proposing 10 steps of optimal mother-baby care. In 2010, the UNU-IIGH published a review of all publications on obstetric violence. They called Exploring Violence, Evidence for the Respect and Abuse in Family-Based Childbirth, Facility-Based Childbirth. And they listed a few different ways of the respect and abuse. And then in 2011, we have the White Ribbon Alliance proposing respectful maternity care. And since then, the White Ribbon Alliance has been a very important partner that proposed in 2015 respectful care, some lines of action. In 2014, WHO published the prevention of and elimination of disrespect and abuse during facility-based childbirth. So we have a progression. In 2015, FIGO, in partnership with ICM, the Pediatric Association and others, published a proposal of mother-baby care, humanized care. And since 2016, we have the WHO working in a new concept. In 1996, they proposed evidence-based practices. They classified the practices in care in 4 groups: those supported by evidence, those that the evidence shows they should be abandoned, and some other groups, one that needs more research, and the others of practices that are used inadequately. So now, since 2016, we have antenatal care, in 2018, intrapartum care, and now 2022, postnatal care. And they bring the concept of woman-centered care. Childbirth care, pregnancy care, postnatal care should become a positive experience for women. And this is really revolutionary because it brings the woman perspective in these recommendations. In 2018, FIGO and the International Mother-Baby Childbirth Organization proposed the 12 steps, the ICI, International Childbirth Initiative, that's being supported by many other organizations. And finally, we have the Respectful Maternity Care Council that is coordinated by the White Ribbon Alliance, and where people who are interested from all the countries can participate. There are more than 70 countries already involved in this council, and I think we can invite you, please, enter, register, and participate in this council, those people who are interested. So we have this international organizations bringing this knowledge and proposing these guidelines that are very important. On the other hand, we have these grassroots organizations, and I will speak mainly about Brazil because I'm more familiar, but I'm sure that all over the world, there are organizations. We are familiar with some in Portugal, in the States, in Mexico, and I'll talk about Relacalpan, which is a Latin American organization. Our organization started in 1993. The Latin American and Caribbean Network for the Humanization of Childbirth, FELACAUPAN, started in the first international conference on humanization of childbirth that was held in Fortaleza, Ceará in 2000. And they have been active in Latin America since then. In Brazil, we have, from 2006 on, Parto do Princípio, where women that use private service or health insurance, they got together because of the excess of cesarean sections in the private sector. And since 2019, we have the Brazilian network of Feminists, OBGYN. So these are groups that have a say and have managed to provoke Ministry of Health policies and all that. If you want to learn more, there is a Reproductive Health Matters publication by all the three of us and some other colleagues that's called Disrespecting Abusing Childbirth in Brazil, Social Activism, Public Policies, and Providers Training. So how we have been working as grassroots? We have performed research, and research gives visibility to this violence, just as Ana Flávia proposed. We have influenced policies. We have done advocacy. We've been to the House of Representatives, to the Senate, to the different agencies denouncing this violence. We have organized national and international events because we believe that people have to have access to knowledge to make informed choices, and this is valid also for professionals. So we bring knowledge, this international knowledge, so they can make informed choices on better care. Diffusion of information. We have put public position statements and influenced public opinion. So this is the way we manage to make our advocacy getting to people. In Brazil, we have the current situation. Well, we had the Stork Network from 2011, and it proposed to change the paradigm. They wanted in 2011 to have 250 new birth centers. Nowadays, they managed to have about 50. So it's very difficult to change the environment of childbirth care. We have made a survey. We identified some other 50 birth centers that are not listed by the Ministry of Health. And they also invested a lot. As Simone mentioned, we need to work with midwifery in obstetric nurses and midwives training. Anyway, we don't have enough till now. We need more training and more schools of midwifery. And they have invested also in qualifying prenatal care. Also, the Ministry of Health in 2016 and 2017 proposed guidelines for normal birth and cesarean section. And they proposed a program to change the way obstetrics and gynecology is taught in 96 teaching hospitals. So this is a very revolutionary program. Unfortunately, it ended in June 2020. It started in 2017. And I think 3 years is not enough to change a culture. Ana Flávia showed how violence is perpetuated in those settings, teaching hospitals. And I remember as a medical student how I learned obstetric violence together with the teaching. So we need to change that. Well, Ana Flávia already mentioned that medical councils are one of the centers of the resistance, the medical category. They refuse to adopt evidence-based care. Simone mentioned that too. And we have some examples. The Medical Council of Rio de Janeiro, since 2012, has been issuing resolutions against humanized care. The Federal Council, Santa Catarina Medical Council too, in 2019, the Federal Council of Medicine has issued Resolution 2232 in 2009 that states that if a physician believes there is a risk for the mother, he can surpass her autonomy. During the pandemic, the Ministry of Health didn't issue any guideline, recommended the COVID-19 kit, delayed buying vaccines, made no recommendation to vaccinate pregnant women. And I think it is an obstetric violence, this avoidable death. We have a very high mortality, maternal mortality rate now that we might consider. It's very similar to the numbers we had in the 90s. So we went back some 30 years in maternal mortality. And I think this is a kind of institutional violence. Besides that, Ana Flávia already mentioned, we had the edict in last month's 715 that destroys the stork network. I won't, Ana Flávia mentioned, and I won't enter in details.
Daphne.
Yes.
We are in the time for the Q&A.
I was in my last sentence.
Okay, thank you. Sorry.
And besides that, we have the pregnant women booklet that they changed it, and the new version doesn't mention women's rights and proposes some practices that should not be practiced on the woman's body. So this is our current situation. Simone, you're without a mic.
Okay, thank you so much, Daphne. There's so much to say. Sorry for us talking a little bit too much. So now we have the Q&A, and I think Sarah is going to help us on that. There are several questions here, and thank you so much for your attention.
Yes, thank you, everybody. I mean, what a hugely rich set of ideas and experiences and even solutions that you've brought into the conversation today. So that there are a number of questions, and I'm going to start with bringing a couple of the questions together, and it's around the issue of definitions. So in fact, Simone, there's a question here from a former student from FSP USP. So and the question is, it says that you mentioned the different terms relating to obstetric violence, and the question is, how do you think that the use of different terms and the multitude of terms affects the reporting and the understanding of the issue? You know, if we can't all agree on what the terms are, can we agree? Can we expect the reporting to be understood?
Thank you. This is a very important issue, and it is on one hand an advantage because it's a frontier object, so it's open to many approaches. We can see it from the health perspective, the epidemiological perspective. We can see this from a law perspective, and so on. The ethnographers see this in other issues. The linguistic people also. In one hand is a richness, the diversity, and is also the customization of the problem to local cultures and languages, and also the issue of diplomacy. We used to say that we use humanization because frequently the providers are not able to hear about violence, about abuse. So some people say we should find the right name for this, but it's an advantage on this openness, But this at the same time is a problem. We need something that's relatively comparable for us to create indicators that could be used in different settings. And I think that the multi-country study that the WHO started, this epidemiology of gender violence, can help us understand how to bring together some commonalities. So there are some efforts on the way that I think there are this is a very hot topic in Brazilian epidemiology, because we think that we have to go further in the epidemiology of interventions in the gender perspective, and also how to define and quantify the issues of abuse in the oversection of the use of unsafe, non-evidence-based care. So how can we put this together in a pragmatic way? This is a very hot topic. And Luana, thank you for the question. Not only Brazil, but internationally. I think that the global, this Lancet Commission can have a role in trying to figure out what would be the commonalities for international, global, collaborative research and action.
Thank you, Simone. I'd like to carry on with the question of definitions and relate this back to something certainly that Daphne touched on, and Ana Flávia to some extent too. So it's a question that comes from Rina Dwivedi in Edinburgh, Scotland. And the question relates not so much to overt definition or definitions of overt violence, but the extent to which we can classify the omission of services as obstetric violence. And the particular example that is given relates to access to legal and safe abortions. So in countries that are currently removing those rights from women, are we defining that as obstetric violence too?
Just to start, because I'd like to Ana and Daphne to comment. This is the situation of countries that have illegal abortions, And yes, this is a very strong form of obstetric violence. And we know that, for an example, in our countries, although abortion is legal, when there's a risk for the life of the mother, of the pregnancy results from rape, of sexual violence, these services are being denied presently. It's very difficult for people to access even those limited rights. So yes, this should be called institutional violence, and I think that we have presently new examples. Ana and Daphne, please.
I want to problematize that because I think we have, there is a traditional discussion in the violence and violence against women sector of what are the limits, and is there any limit between gender inequalities and discrimination and gender-based violence. So I have this trend, but I think it is very, we have to think a lot about that. What are the limits for the word violence, and if violence, gender-based violence, is the same as gender-based discrimination and gender inequality. It seems to me we have other terms like reproductive justice and reproductive coercion that could be applied more to this sort of acts. And we could think, strategically to reserve gender-based violence and obstetric violence for for the humiliation, threatened, physical abuse that happens a lot around the world. So I think we have to think how much we gain. You see, and Simone mentioned the WHO multi-country study. What we did to compare intimate partner violence, domestic violence around the world was to focus in acts, irrespectively of what was the woman meaning to the act. Because a woman can say her husband slapped her, but she didn't suffer violence. So I think here is the same. We have to have a set of acts that we will call violence, and maybe a set of unfair distribution of health care that we call, you see, gender-based inequality. Because obviously, the lack of safe abortion around the world is a cause of maternal mortality, and it is, you see, it's terrible for women's determination. But I don't know how much we gain or we lose in putting everything together under the umbrella of obstetric violence. I don't know if I was clear. It's just open to the debate.
What I would add to this discussion is that I can see different levels of violence. And we've been discussing a lot the interpersonal care violence, but you have institutional violence. For instance, racism is an institutional violence. If there is a right of the companion of choice of the woman and the institution doesn't allow, then you have it in the level of the institution. If you don't have protocols, this is institutional violence. Then you come to the health system level. In the health system level, for instance, if the woman doesn't have a hospital bed and she needs to peregrinate from one hospital to another to get a bed so she can have her birth attended, this is the level of the healthcare system. And then you have the societal level. For instance, if you don't have laws that guarantee women's rights, I think you may call it some kind of violence too. So we can look, like an onion, you have different levels and you get to different levels. And see, racism is something from the social level, but it reflects in the interpersonal one. So they interact all the time. And I think when Simone said in the beginning, intersectional violence approach, yes, these are the intersections. But these are different ways of reading the same phenomenon.
I'd like to thank the three of you for such very thoughtful responses to these questions. And just to let you know that actually there's a whole number of questions that have come in that really segue on from, I think, where we've just reached in this conversation, that the issue of individually experienced violence has multiple layers, multiple causes, from the kind of more proximal to the woman on the receiving end of the abuse and discrimination, right up to the systemic and structural issues that determine not just the woman's risk, but how the health system is set up and who runs the health system and who's delivering care, and et cetera, et cetera. And many of the questions, which I really thank the audience for. They are incredibly thoughtful questions coming in from everybody that really touch on the complexity of an issue such as violence, obstetric violence, broadening out, as Simone has just mentioned, into issues of reproductive justice. These very much are the kinds of areas that we're grappling with across the Lancet Commission, situating inequality not just as an individual experience, but also as something that is embedded within the systems and structures that we all operate within, and that it's the systems and structures that need to change as much as we need to change as individuals in our practice. So once again, a huge thank you to Simone, to Daphne, and to Ana Flávia for a really enriching conversation. And I know that lots of people will be disappointed that the conversation is ending here, but if I could just have the final slide put up, please, to remind you that whilst this conversation has just reached an end, we will be carrying on with further conversations. In fact, the next conversation also has a Brazilian tinge to it, because it's a conversation with Gary Barker, who is the co-founder of what was Promundo, is now Equimundo, brings a lot of experience understanding issues of masculinities and the health of men, not just in Brazil, but globally. And so a huge thank you once again to everybody who participated in today's conversation, and very much look forward to seeing you all again, hearing from your comments and questions again next time with Gary Barker. Thank you.